we learn about important medical conditions and topics through the experiences recounted to us by people who've had these kinds of problems. Today we have a very special audience, a group of people who have gone through some very significant lung problems and one patient who's been through a significant heart problem. They've all had progressive lung problems that have required a transplantation. So we have a very interesting group with a diverse number of diseases, but diseases that you may have heard of, diseases that are really out there in the world and you need to be aware of and understand. Cystic fibrosis, chronic obstructive pulmonary disease, COPD as it's called, interstitial pulmonary fibrosis, pulmonary arterial hypertension. These are all important diseases for you to understand and to get some insights as to what organ transplant is all about. We have a great audience here. We have also one of the foremost specialists in the country on pulmonary diseases of this nature, Dr. Stephen Nathan. Thanks for being with us, Dr. Nathan.
My pleasure.
He is the director of the Progressive Lung Disease and Lung Transplant Program at Inova Fairfax Hospital. So, as we get into understanding where your diseases came from, is there anybody who wants to give us a little insight as to, well, when you first started to develop some symptoms that really started you on this road to where you ended up with that progressive kind of problem? Anybody remember the first times they had those kinds of respiratory symptoms and they started to realize this was something worse?
Hi, I'm Jim Lawrence, and I first realized I had something wrong when in 2000, January, when I was getting colds and they weren't going away. The only way I could get rid of a cold is through antibiotics, and it just kept coming. So I finally went to a pulmonologist who indicated I had a serious lung disease.
Now, there are lots of people who get lots of colds and say they're sinus infections. Oh, I've got bronchitis. Was yours something more significant than that? Were you having other
with
pulmonary symptoms? Were you wheezing?
With my,
things like that?
the doctor, which was a general practitioner, heard what we refer to as crackles.
Right.
And crackles is a major symptom with IPF or probably any other lung disease.
Right.
And that sent me to a specialist.
So, and then you had a pretty rapid course in your problem there.
No.
No? I mean, relative to those sorts of things, over what period of time until you got sick enough to really end up seeing somebody for this?
It took almost 2 full years before I really felt having a real problem.
Yeah.
And that was because I had a number of things happen, like a heart attack and
Oh, you had some complicating features there.
quadruple bypass, and then I had a lung transplant.
Wow.
So
that's a story in and of itself. We could make the whole show around. Anybody else have some recollections of those first symptoms they had?
My name's Ken Kurz, and last fall when I was mowing the yard, I noticed that I got kind of tired. With my age, I dismissed it and said it was age. Come November, I came down with a cold. They thought it was pneumonia. In January, I had a biopsy, diagnosed with IPF, and in July, I was transplanted. It was that quick.
That is a quick course.
Yeah.
And you were going to tell us as well.
I'm Chris Campbell. In the fall of 2003, I'd never had any real medical issues in my life. I started to become short of breath. And as that progressed over the fall, I realized there was something wrong with my cardiovascular system. Went to my general doctor. He diagnosed nothing, but he did send me to a cardiologist. They ended up finding that my lungs were full of blood clots, which at the time they said was fine because I was alive still, and they sent me home on blood thinners, telling me I would get better, but as it turns out I didn't. I developed pulmonary hypertension from there, and the course went downhill very quickly. I was on oxygen 24 hours a day within a few months and was transplanted about a year after that.
Wow, that's a quick progression too. And one that's a little different. So we've heard a few different and interesting ones. And you were going to tell us how yours started.
Yeah, my name's Mike Parker, and my first symptoms were probably in 1995. I was a 2-pack-a-day smoker, and kind of knew what was wrong before I ever went to a doctor. And when I went, he sent me to a pulmonologist who diagnosed emphysema. And just couldn't quit smoking. It was just, and when I did, it was the hardest thing I ever did. But then in 1999, I had 3 or 4 hospitalizations for what they call an exacerbation, which is like a lot of fluid in the lung and things like pneumonia. And I guess it was 2000 or 2001, I went to see about lung volume reduction surgery, another type of thing, and I wasn't a good candidate for that. But the people, this is in St. Louis, the people in St. Louis referred me to him, to Dr. Nathan. So we looked at it for about a year, and then between us, we decided that the window was there to do it. And I guess the most extraordinary thing about my transplant is I waited 13 days.
Wow, on the list. So
Yeah.
that was remarkably quick,
Yeah.
right? And you probably really needed it at that point.
I was really sick.
Yeah.
I was very sick at that point. I think you probably would have wanted me to do it a little bit earlier.
Yeah. You okay?
It's different. My name's Lolly Gilmore,
Hi, Lolly.
and I also had IPF, as did a few of the previous people. The difference is the IPF can move at different rates. When I was 40, I had never had, I couldn't remember the last time that I'd had a chest x-ray. So I had that done. And there was on the x-ray feathery profusion of white stuff. And we didn't know what it was. And so my husband and I were going, oh my God, is it cancer? And the physician said, well, if it was cancer, you'd probably be dead by now. You'd be really sick. So it took a while to figure out that it, we came back in 6 months, maybe it's scarring from pneumonia, and had the open lung biopsy and diagnosed as IPF. This was in 1990. The symptoms came gradually. Not being able to play singles tennis, playing doubles tennis, playing really lousy doubles tennis, playing so badly that people didn't want you on the team anymore. And then in 1997, it suddenly escalated. Prior to that, I had even thought that maybe I was misdiagnosed, because now it's 7 years had passed. It was the end of 97, so as I said, it accelerated very rapidly to the point that I sold my house because I couldn't get upstairs. I took my oxygen tanks everywhere. I was actually in hospice care when the call came. Wow. And that was in May of 1999, so the course of my disease was a lot longer.
Well, we're going to hear a lot more from you all in terms of the course of that disease. There are two things. One, I guess, finding out a little bit about the anatomy of the lungs, just so people can get a little refresher on that and understand what happens when some of these diseases affect the way they can breathe, that get to the point where they have to have something like a lung transplant.
Well, the lungs really function as the organ that does two things primarily. It supplies the rest of the body with oxygen when we take a breath in, and it eliminates carbon dioxide. And there are many different diseases, some of which you've heard about, that can affect the ability of the lungs to be effective in this regard. Pulmonary fibrosis, COPD being another one, cystic fibrosis, sarcoidosis, a bunch of different conditions that can cause advanced or end-stage lung disease. If you look at a condition like IPF, it's characterized by progressive fibrosis and scarring around those little air sacs that are in the lungs. These are very delicate structures, and any component of scarring is going to compromise the ability of the lungs to take up oxygen and, by the same token, eliminate carbon dioxide. With IPF as well, the lungs get very stiff from the fibrosis, and the fibrosis tends to be progressive, so that it is a condition that generally has a very poor prognosis, with an average survival anywhere from about 2.5 to 5 years. And I think you've heard some of that course described already by some of the patients. Emphysema that Mike has over there, or had over there, is a different condition. It tends to be a little bit more indolent. That's primarily from cigarette smoking. There are some inherited forms of emphysema, like alpha-1 antitrypsin deficiency. But what happens is you actually have destruction of the alveoli, and there's so-called air trapping in the lungs. The lungs actually get bigger, and get big to the point that it compromises patients' ability to take air in and out. So if you want to imagine what it's like breathing with emphysema, I always tell patients' families, if you want to imagine what it's like for your loved one to take a breath in, take a deep breath in, and then try and breathe around that, and you can see how difficult it is taking air in and out near your total lung capacity. And that's a major problem with emphysema. Another condition we heard about is pulmonary hypertension, pulmonary vascular disease. The pulmonary artery is the big blood vessel that takes blood from the right side of the heart into the lungs, where it collects oxygen before it goes to the left side of the heart and goes to the rest of the body. In pulmonary hypertension, you have a buildup of pressure in the pulmonary artery that affects the ability of the right side of the heart to pump blood through to the lungs to pick up oxygen. And that leads to progressive heart failure of the right side and something that we refer to as cor pulmonale. Pulmonary hypertension can occur as an idiopathic or an unknown phenomena. It can occur secondary to chronic thromboembolic disease, that is pulmonary emboli that fail to resolve, like Chris over there had, or it can occur secondary to other forms of advanced lung disease, even COPD, IPF, and especially sarcoidosis as well. So those are the three of the conditions we've heard about. Another condition is cystic fibrosis, which is characterized by airway problems, secretion clearance problems. It's a congenital or inherited condition, and excuse me, those patients generally tend to be younger by the time they come to have the need for transplantation.
Now, getting back to Mike and your COPD or your emphysema, and of course, people probably wonder, about cigarette smoke and the fact that there was a generation that really grew up with cigarette smoke being rather commonplace. And even if you chose not to smoke, you didn't really criticize people who did around you. And we come to understand now that it's just as bad to be around it as it is to do it yourself. And anyone who smoked knows it's one of the hardest things to kick. It is as addictive as any narcotic could ever be, and even worse because it's so available and you're always around some sense of it. So it's a difficult thing. But emphysema, COPD, I mean, that's 12 to 24 million Americans. They say it's somewhere $40 billion a year in terms of medical expenses to this country, which is a really remarkable thing to know about. And there are some symptoms there that Dr. Nathan's describing that are kind of interesting. And I guess it's that sense of not being able to really get that full breath of air as your lungs start to disintegrate, literally under the stress of the disease.
Yeah, it gets worse and worse, yeah. And this went pretty quickly, actually, from a point where I could do something to the time of the transplant was real steep slope downhill. And Dr. Nathan described it perfectly. The other thing I would tell somebody to do is to, if they want to know what it feels like, maybe take a straw and trot around the block. And don't breathe through anything but that straw. Clip your nose, and then you'll get some sense of trying to get a breath and the anxiety that goes with it.
And the barrel chest, that's the big
Yes.
chest, as people keep trying to breathe more and more and their lungs
Yeah.
hyperexpand. It's something to be aware of in terms of people that you may know who have those kinds of outward symptoms and cough and complain about that. Is it a productive cough? I mean, do you cough up a lot of stuff when you have these kinds of coughs with
Yeah, I did.
with emphysema?
Yeah, it was productive. Mine was a productive cough. And once I was able to produce whatever was in my lungs, it was noticeably easier to breathe. But I had to do what they call a nebulizer, which is an albuterol type thing, and to keep it open. And it was very frightening, very, very frightening.
So those are the kind of medicines that you would use for asthmatics. They probably don't give you the same level of relief because it's a different disease.
No, I'm not sure. It may, that there really is a medication for COPD. Oxygen, and they say Spiriva, a new drug, is doing okay, but I never got much relief from anything. I mean, I did what the doctor told me to do, but I didn't get much relief from it.
So the diagnosis is basically that history, as you described it, and then you do a chest X-ray. And
Well, COPD is a very common condition, as you mentioned, 12 to maybe 20 million Americans, depending on how you define it. The patients who progress to real severe disease, like Mike had, are thankfully a much smaller minority. But one of the problems with COPD is because it's so prevalent, a lot of these other disease conditions, like idiopathic pulmonary fibrosis, pulmonary hypertension, get misdiagnosed as things that are more common, like COPD or asthma. So a lot of folks who have these rarer conditions will go a couple of years before the appropriate diagnosis is made. Sorry, go ahead.
Yes, no. Please continue. Hear the authority. I'd love to hear it.
So, that's a real issue for us, is awareness of all the conditions and the option of treatments that are available. If you look at lung transplantation in the context of all these diseases, that's where all these diseases come together. They all have different pathologies, pathobiologies, different cells, cytokines, etc. involved, but all of these diseases can advance to the point of being very advanced or end stage, where the only resort is lung transplantation. So lung transplantation is really a last resort form of therapy when all else has failed. Excuse me. And how we decide when someone's a transplant candidate is really a balance between the risks and the benefits in terms of knowing when the timing should be right. And that can vary for each individual patient depending on what their comfort level is in terms of outcomes, what their expectations are, what their quality of life is. And for each patient, it becomes a very individualized decision.
And I'm sure that you learned a lot about emphysema, and I guess, are there things people can do to prevent that occurrence?
Don't smoke.
Don't smoke. That's
Yeah,
number one.
don't
How about
smoke.
pollution? Is that an issue for you?
That was never. It was cigarettes. I mean, I could say it was pollution. I could say it was. I was in the construction business for 30 years, and that certainly didn't help. But it was cigarettes that did it. And I think it was just the most important thing to get across to your kids, just how bad it. My two younger kids wouldn't touch a cigarette with a 10-foot pole. I mean, just seeing what I went through.
Yeah.
So that's what you can do now is just the research that the doctor's going to do and get young people to quit smoking, because that's what did it.
The most important thing. Yep. You have a unique cause for your kind of problem, in that you said you have sarcoidosis.
Had
You
sarcoidosis.
had sarcoidosis. All right. Is it something you can have and then not have?
No, once you have sarcoidosis, it's there.
Right.
I was diagnosed with sarcoidosis once I came out the military and I went on a new job and had a physical done.
Right.
And they saw the scarring on my lungs.
So this was just a routine chest
It was just a
X-ray?
routine chest X-ray, and they saw the scarring.
You had no idea?
Had no idea.
No respiratory
Well,
symptoms that you were aware of?
in the military, I did have some because I was running 5 miles, and then gradually I was like, okay, I can't get through 2 miles without huffing and puffing. So I didn't know what it was. Felt the cold, didn't go away. Thought it was something else.
Sure.
Over-the-counter medicine wasn't working. Again, when I came out of the military, got a job, went on a routine physical, and they saw the scarring. And then I was diagnosed with sarcoidosis, and that was in 1989. And they treated with prednisone back then.
Right.
And the disease had done what it had done. The damage was done. But I was still able to function quite well. Oxygen level was still high. And eventually weaned me off of it. Probably about 5 years ago is when I went on oxygen, about 2 liters of oxygen, off and on. Got progressively worse. And last year, this time, I literally collapsed in my house from lack of oxygen and was hospitalized. And that's when I was diagnosed with the secondary pulmonary hypertension. And my doctor then, Dr. Sang, referred me to Dr. Nathan's office in May, was when I first went to meet his team, was in May. And they started me then on Revadia and Traclear, the medicines to help open up those vessels some so that I could breathe a little better. However, I was still on a high level of oxygen. As they were doing the pre-lung transplant evaluation, I ended up being on 10 liters of oxygen by the time I was accepted as a patient in September. I was actually officially listed for a lung transplant on October the 17th. And I was actually transplanted on October the 22nd.
Wow.
Double lung, both lungs have,
Well,
both lungs had to
at
be.
10 liters, you don't have many liters to go. It's hard,
No,
it's hard to get
no,
many
no,
more
yeah, 'cause at 10
molecules of oxygen
Right.
before you.
At
that
10
point.
liters, it was very rough because you play a game between your nose being dried out because I couldn't use the humidifier anymore at that point because they had an oxynizer on me, and it made my nose extremely dry. So therefore, you run the risk of having nosebleeds. Well, it's kind of hard to have a nosebleed and a nasal cavity up your nose at the same time. And as it would be, I was at church that Sunday morning and came home, and I felt at church my nose was starting to bleed. Actually, I could feel those blood vessels starting to burst, and I could touch the blood. And when we got home from church that morning, they called and said we have a lung. And I came to the hospital. My wife and I got there about 1 o'clock that afternoon. By 6, I was prepped. By 11, the lung was in. It was in the hospital. By 1, Dr. Burton was finished. He did it in 4 hours. He gave my wife and I an estimate of 8. He did it in 4.
And if you don't mind me asking, how old are you now?
I'm 45.
45.
Yeah.
So, and this is, the sarcoidosis is a rather, it is a hereditary pattern?
It's not hereditary, it's really unknown, it's idiopathic, which means we don't know what the cause is. It's also a fairly common condition. Actually, after COPD, it's the second most common condition that we're talking about, but it's only a few patients who go on to need transplantation that it can actually spontaneously resolve. And it's about 10 or 20% of patients who have progressive disease, like Donald's describing. If you look in the context of transplantation, only about 2 or 3% of all transplants are done for sarcoidosis, even though it's just second behind COPD in terms of being common. But that can be a very typical kind of course that is being described in terms of someone who develops secondary pulmonary hypertension, complicating diffuse fibrosis in the lungs, this time secondary to sarcoidosis, not idiopathic like the IPF we heard about earlier.
So we're talking about the IPF, which is not really the pulmonary arterial hypertension, where the blood vessels are having a hard time getting blood to and from the lung tissue.
Very different.
But it is the same basic inflammatory process, but a different cause.
Yeah, sarcoid has its own distinct pathology. It's characterized by granulomas in the lungs. It can affect other organs as well, although the lungs are the most serious organ generally to be involved by sarcoidosis.
And those granulomas are basically the scars he was pretty much talking about, or the result, or cause those scars.
The scarring results from the granulomas.
Right.
Yeah.
And then we heard from Chris, who had a pretty, well, another complicating course, and you're a pretty young fella who's had to go through a lot to get to this point. And you said you had problems with blood clotting. And had you been aware of that? Did you have any insight or awareness of what that was?
No, I mean, as I said, I had been healthy my whole life with no issues with really anything. So at age 35, when I started to become short of breath, I thought, I'm just getting older, need to exercise more. But the progression was fairly rapid to the point in, I think, December of '03 that I could go up one flight of stairs and need to stop, for 20 seconds to catch my breath. So at that time, I knew something was wrong, more than just being out of shape. So they found the blood clots, and it's idiopathic. We don't know what the cause of my clotting disorder is. Just like the pulmonary hypertension, it's unknown for me whether the clots came first or the hypertension that might have caused the clots.
So there's no family history, there's nothing like that in your family
No.
that has occurred?
No, I've been through all of the testing for both blood clotting and hypertension to look at known causes, and everything came up blank.
Right. So pulmonary arterial hypertension, you say that there is the opportunity to use some medicines that can sort of give people at least a spell of improvement. Is it invariably going to progress?
Not invariably. If you would have spoken to me about the subject 10 or 15 years ago, I would have said yes. We didn't have any effective therapies at that time for pulmonary hypertension. But that's the one condition in pulmonary medicine where we've made some real advances. And now we have 5 FDA-approved medications that we can treat pulmonary hypertension with. So Chris experienced some of those, but unfortunately there are some patients who will progress despite therapy.
And then we have another disease process that is unique and one that's very interesting. And me being a pediatrician, I deal with a fair number of kids over the years, but cystic fibrosis.
Right.
And I guess cystic fibrosis, as we were identifying before, is an inherited disease.
Right.
At what point were you diagnosed?
I was diagnosed at 1 year of age.
At 1 year of age.
Yeah,
So
actually,
it wasn't even in the newborn period. Nobody had any idea in that first year.
No, actually, my mother diagnosed me because she got the Dr. Spock book out. She noticed the failure to thrive, the sweaty, salty skin that I had, that I was sick all the time. She went to my pediatrician and said, "Hey, I think she has cystic fibrosis." The pediatrician said, "No, that's not possible. You don't have it in your family." Whereas we actually did, but it was generations previous that it wasn't called cystic fibrosis back then. And she insisted on me being tested, and sure enough.
Well, it's not an uncommon condition, somewhere in the 1 in 2,500 or so
Right. Have the gene.
in the general population. More often that Northern European descent. But it doesn't mean that it doesn't affect other people, because there's been so much admixture of the gene pools around the world that you will see it, but in lower frequencies in other types of populations. When you have cystic fibrosis, obviously there is an alteration in some kind of function. What's the typical course?
Well, patients generally get recurrent infections. The spectrum of the different organisms that cause these infections changes with the patient's age. And as a result of these infections, you get progressive scarring and destruction of the lungs, to the point in some patients where they ultimately need a transplant, where the lungs are destroyed, that there's no other alternative. We are getting better in our management of patients with cystic fibrosis. So if you look at the average age of cystic patients, it's steadily going up and up. And I think the latest I heard or saw was around 32 or something like that, whereas probably 10 or 20 years ago, the average age of a cystic patient was around 18. So there are small advances made on a year-by-year basis in the management of patients with cystic fibrosis. And in fact, we've seen patients who are in their 40s and sometimes their 50s now who have cystic fibrosis, and some of them coming to the point of needing transplantation.
It's amazing, and I'm sure that you've been involved with a lot of people who have the same disease, whether it be going to your pulmonary docs or just in terms of the organizations that you get involved with to understand better and to commiserate, I guess, through the process of a disease. Usually you see it early in life, but not always. There are some people who just uncharacteristically present later, but usually, you know, as a pediatrician, I'll see a baby who's not growing well. There is some suspicion based upon the kinds of respiratory infections. They get more progressive and worse as they get older. And they're always getting ear, sinus, and other kinds of things. Was that an issue for you while you were growing up? I mean, did you have a lot of infections?
No, I was in the hospital maybe once a year, once every 2 years with, getting antibiotics for the lung infection and whatnot. It wasn't until right after I got married, when I was 28, that I got very sick very quickly, which can happen and sometimes not.
So it was more related to an infection at that point that
Yeah,
just caused enough injury to your lungs so that it sort of hit that critical mass?
Yeah, I just got very sick. I went into the hospital for the normal 3-week course of antibiotics, and I just suddenly went into respiratory failure. And that was right before Christmas, 6 months after we got married in December of '97. I don't remember the month of January. I was pretty out of it. I had to have a tracheotomy. I was on the ventilator for about 5 months, and that's when I met Dr. Nathan. He evaluated me for transplant and got accepted into the program. And I was actually transplanted the same day that I was listed.
Wow.
Only because I was about 9th on the list, but I was the only one with B-type blood, and that's what type of lung that came in. So I was the only one that could use them. So right place, right time.
Yeah. And you're her husband.
Yes.
And you knew what you were getting into in the first place.
Yep.
Did you have any idea that it would come to this?
Not really, I guess, in the beginning.
And I guess
just thought, the normal course of the treatment she was going through as we were dating and stuff was what we was gonna have to deal with for the rest of her life. But
who was more frightened at the time when the transplant was decided upon?
Oh, I told Dr. Burton, the surgeon, I said, bring it on, I'm ready.
Right.
So I didn't. I was
so
asleep
we know who was
through
more
it, so
frightened, right?
I just had to sleep through it. So
Yeah, a hard thing to sit through. How long was the surgery for you?
mine was about 7 hours. Is that right?
Yeah.
Yeah.
And was it both lungs?
Both lungs, yeah,
Both
double
lungs.
lung, yep.
Okay.
Yeah, I
And does everyone get 2 lungs when they get a transplant?
No, it's actually, if you look at the patients we do, about 80% get single lungs and 20% get bilateral or double lungs. The only condition where you have to do a bilateral lung is a patient with any form of septic lung disease like cystic fibrosis, because you don't want to leave in a source of infection in the native lung that's going to spill over and affect the other lung. In Donald's case, as I recall, some sarcoid patients do get bilateral lungs, but I think he might have had a fungal infection in his lungs at the same time, or because of his severe pulmonary hypertension that we decided to do a bilateral lung.
Okay. And then what was the condition, the situation for you?
I had idiopathic pulmonary fibrosis.
IPF, yeah.
And that was tough to diagnose with me because I'm 33. I was 33 when I realized something was wrong, and just I was a stonemason, which they thought, well, maybe that has something to do with it, but in carved stone. But there was, when they in May of 2005, when I was working on a project and I'm just carrying some stone up the stairs, it was like 2 steps and I was ready to fall over. And it was very quick with me. I mean, even I think there was clubbing that was noticed the fall before, in the October before, in my hands and my fingernails. But as far as respiratory-wise, I didn't really realize there was anything wrong until last May, or May a year ago. And then they thought it was interstitial lung disease was the umbrella, because everything that they found was sort of like all across the board as far as the pathology in my lungs. So eventually, I saw Dr. Nathan last summer, and it was just progressing like IPF. So we figured that must be what it is, and sure enough, it progressed very quickly with me. I was on oxygen almost immediately for like a year and a half, and it got to where, even though I could get stronger with rehabilitation, eventually I hit the limit, and I was I had a mask on with like up off the wall oxygen, like with 12 liters, trying to do my exercises and stay strong. And by October of 2006, we were going through the transplant, made the decision and got evaluated. And I was kind of quick too I got my letter on I guess it was the 14th of October, and I got my transplant the 15th. So
That's impressive.
But I didn't, if I would have gotten pneumonia or something like that, I only had 20% of my lungs left to help me out. So we just were afraid I wouldn't make it till Christmas. So
A stonemason.
Yeah.
Now, there aren't a lot of stonemasons around, and there aren't a lot of ladies who carry stones upstairs. So
I was pretty strong before.
I bet you were.
No, there wasn't. And I'm a craftsperson, and I loved to build things, and stone is just a beautiful material to use. So I kind of used my artistic background with the trade, as to say. So
Now, silica, or stone dust, that's a pretty irritating substance.
Yeah.
Is that known to be associated with any of these types of diseases?
Well, silica can cause silicosis,
Right.
which is an inhalational form of lung injury that can result in pulmonary fibrosis as well. We wouldn't call that idiopathic pulmonary fibrosis. Idiopathic means we've ruled out everything else and there's no cause that we can come up with. So it's a distinct clinical entity, and silicosis is a distinct clinical entity as well.
So, a pretty fascinating story there. When we talk about transplants, we're talking about a really very significant and incredibly life-altering decision. And I don't know how people can decide, gee, it's time for me, I can't stand living this way anymore. You were on buckets of oxygen. You couldn't carry anymore, and at that point you needed some basic lung tissue. Is that what it comes down to for most people?
Well, everyone's different. We talk about a window of opportunity for lung transplantation. We don't want to do patients when they're too early, and we don't want to do them when they're too late. We try and catch them within this window of opportunity. Some patients can move through that window very quickly and become almost too sick to receive a lung transplant. So the trick is to try and get patients as early as possible, follow them along, and then decide when the appropriate time is when they're in that window of opportunity. And it's difficult with some diseases. If you take a disease like IPF, for example, where we know it's going to progress, we just don't know when it's going to progress. It's very hard talking to patients about the need for transplantation when they don't have much in the way of symptoms. They kind of look at you like you're crazy, and they will tell you when they need the transplant. And I think we have some members in the audience now who will tell you a story like that. And it's a difficult conversation to have, because sometimes I'm breaking news to them that they have no idea about. Idiopathic pulmonary fibrosis means idiopathic, we don't know the cause. Pulmonary is lungs, and fibrosis is scarring. And often what is presented to patients is, oh, you have a little bit of scarring in your lungs, which sounds like it's a pretty benign condition, but it acts almost like a malignancy in that the scarring is progressive and relentless, and ultimately patients are going to succumb to that condition. And patients can be going along, and then kind of nosedive off the edge of a cliff from their pulmonary fibrosis. So the key is to get patients early enough that if they do have the sudden decline, you can get them transplanted as quickly as possible.
So Lolly, you were telling us that you went on for quite a while before you ended up really getting to the point where you needed a transplant. Were you in denial at all? Or were you just really able to cope with it? At what point did you decide, this is important, I better?
Well, I don't think I was in denial because I was being followed.
Right.
So, no, I wasn't in denial, but a transplant wasn't even mentioned to me initially. I mean, I knew I had IPF. I did all this research to find out what it was, but transplant wasn't mentioned until 7 years or so, well, 6 years at least, after I was diagnosed with it. And I had gone to a new pulmonary physician who took one look at me and said, "You need a transplant." And then I was in denial. Well, wait a minute. Why are you telling me this? Nobody else did. I'm fine. I just don't breathe very well. And that was my mantra for, until I was in bed and couldn't get out to go to the bathroom. People would come in and I'd say, "Why are you all so sad?" I feel fine. I just can't breathe. Well, that's pretty important. So I don't know if you would call that being in denial. I don't think so.
Well, I'm not really sure about that. But, it's somebody who wants to live and somebody who doesn't want to accept any defeat whatsoever. And you were a liver. You are absolutely there.
And
how do you live your life with it?
I knew I was going to, I had seen no knowledge of the statistics. Nobody told me. So I just knew that if I was laying in bed long enough and not taking too deep breaths, I would eventually get a transplant, which, as you see, I did. And I'm sorry I interrupted you. What was your next question?
No, that's fine.
But here's the thing. I'm still like that. And, the hospice people have told my friends and relatives, she's got 2 weeks at the most, and they're all looking so sad. And again, I'm going, well, why are you all so sad? I'm not sick. I just can't breathe. Well, early one morning, like at 5:30, 6 o'clock, the phone rang, and I'm in there going, oh, my God, that's got to be a wrong number. Who in the world will be calling me at that time of morning? Well, thank God my daughter, who has more sense than I do, was there spending the weekend, and she answered the phone. She comes in, and she said, Lolly, what's the best news you could have? I said, oh, we won the lottery. She says, no, there's the lung for you at Inova. Come on, get up. And I mean, it was like, oh, okay, but do I have to get there so fast or so early? I can't move too fast. I had to call a friend whose husband carried me down to the car. And of course, maybe I wasn't in denial because I said, I'm driving. You're not, because she makes me nervous, and I had, like 6 oxygen tanks in the car.
As long as you didn't have Mike smoking a cigarette.
That's right.
You're okay.
And I told Doug, I said, put me in the driver's side, and he's carrying me all the way. My daughter's going, no, okay. And the poor guy's going back and forth and back and forth. So, mine was a last-minute deal.
Right.
It really, really was. I mean, when I look back now, I was, very, very sick.
So you went through a transplant. You knew that your days were numbered. You were in hospice.
Yeah.
I mean, that's
and
about
I
as
knew
close
what that
to the
meant.
number.
I knew what that meant.
Yeah, that's as close to knowing the number as you can be.
Mm-hmm.
And then you decided to do this, and it's been a few years now.
It's been almost 8 years.
8 years. And how much of your life have you gotten back?
Oh, maybe more.
More?
Because
You can't remember your life being full.
Well, when you come so close to dying, I think you maybe get a little bit different view on life. And I see Mike shaking his head. You don't sweat the small stuff. You do things that you hadn't done before. Life is short, and you've got an extra, another chance to experience, another chance to open your eyes. So I try to travel, as much as I can. I have 4 grandchildren now that I wouldn't have seen. I stay really active, and I'm in rejection now, so I'm supposed to be kind of sick, but I'm never home, and there's never enough time in the day. So, and my husband, he died of a heart attack at the age of 51, and I saw him go like that, and that was another thing, life can just. You can fall off the edge of the cliff anytime. So you've got this second chance. My God, if you're not using it wisely, then give it a lung back.
Right.
Somebody else wants it.
Well, and we're talking about something that's pretty interesting. And I do want to hear a few more stories in terms of the decision and how it happened, and did you get your family involved with the idea of having to get a lung? Did your family help you decide, or?
Yeah, but decisions is yours,
It's always yours.
obviously. And when I was faced with it, I thought, as you were talking before, I don't need this. I don't need it. I can breathe. I have oxygen. Why do I have to have this? But I also had gone through a period of the fast decline. I lost 15% of my breathing in 3 weeks. And they were concerned about that happening again. And I was concerned. Basically what I did is we got the notification as to whether I wanted to be listed or not. I took a day and slept on it and said the next morning, it's a go. For better or for worse, I can't get much worse than I know the road I'm going down. This was an unknown, but yeah, I would take it.
And Chris, you had to make a decision, but you probably had to involve someone who may have been probably, once again, even a little bit more disconcerted than you might have been. How did it go for you guys when that became clear that that's where you had to go?
I think I had the exact opposite case. I did too much research, and I wanted Dr. Nathan to try every single drug, and he came to the decision much before I did. I mean, I just thought, he's 34 years old. I was pregnant with our 4th child, 9 months, pregnant, and he went in the hospital about 3 days after the baby was born again. So I don't know. I was definitely after you when I made that final decision, but he was in the final stage of heart failure. And so
you're in a situation there where you know when you choose transplant that there is
I knew every statistic.
finite element that you have to acknowledge when you make that choice. So quality of life is very important, and faith in medical research and the evolution of the science so that people can find ways to keep people alive longer after a transplant. But if you can't get that oxygen, you won't have any opportunity for that. And when you had to make that decision, did you get a lot of family support for it as well?
Oh, yeah. My
The
family.
decision was sort of taken away from us because in Jim's case, he was really fine for 2 years. I mean, playing golf and, and 2 weeks before he had the transplant, he finally started using oxygen. And my children and I happened to be up in New York on vacation, and Jim was home, and he said, "Oh, don't worry, let the kids finish the sailing program." And okay, fine. And the next thing I know, his daughter happened to be visiting from Seattle, and he woke up in the middle of the night in complete crisis. And if they hadn't been there, he would have died right then and there. And so called 911, rushed to the hospital. The next call I get is that Dr. Nathan is saying they've put Jim into a medically induced coma. And I said, well, he's going to be fine, right? And it was the first time I ever heard Dr. Nathan say anything that was like, maybe not. And it was such a shock because he had been so fine for so long.
I can't imagine a medically induced coma is a okay thing to be.
So we rushed home. The
into.
boys, Justin was 11, Brooks was 15, and we rushed home. It was the longest trip of our lives, and ran into the hospital room, and here, little Justin sees his dad all hooked up to all kinds of machines, and in 1 week he fought whatever it was, an infection, or Dr. Nathan thought it was the progression of his disease had suddenly just gone off the cliff, and he was able to come out of it because his temperature had gone up to 106, and so he kind of fought through all that, and when he woke up, he was completely out of it. He had lost 30 pounds, and he wasn't a big man to begin with, and he was just very weak. And 2 days later, Dr. Nathan said, well, we have a lung for him. And I thought, a lung? He can't even pick up a spoon. How's that going to work? And he got, actually the lung transplant took, I think, an hour and a half, and the actual surgery. And he got through that part of it just fine. So it was really, the aftermath was almost the worst part.
Yeah. So having to go through the recovery process?
That was
was
terrible.
bad.
That was a tough.
Because he was so weak that he stayed in the hospital longer, and He couldn't walk. He had to have a walker. He became a full-blown insulin-dependent diabetic overnight, and he had one infection after another, had multiple rehospitalizations over the next 6 months, and eventually it all kind of settled down.
Did you see she was there with me all the way?
Yeah, well, it didn't sound like you were going to be in control of much.
No.
At that point, no.
Either Dr. Nathan or the surgeons or my wife, one or the other.
Right, right.
But
Well, that's
all comes out to the good at the end because of his organization and how he supports us.
And we have someone else here who didn't have a lung transplant.
Had a heart transplant.
Had a heart transplant, which is, I guess, something that people hear about probably a little bit more prominently than they do lungs.
I think so.
And the cause of your disease that required that
Idiopathic, right, also.
is also unknown in terms
Right.
of the cause, although we think that it could be anything from a virus to who knows
Genetics.
what.
Yes.
And you had cardiomyopathy, as we call it, or just basically a sick heart muscle.
Right.
And how old were you when that happened?
45.
45. And any awareness? I mean, were you feeling sick? Did you
No.
have chest pain? You just started to get short of breath?
I thought I had acid reflux, which I think I do, but that's what I was being treated for.
Right.
And you can ask all my friends here. I would say, I just don't really feel good today, or this happened, or I got dizzy, or that. So they think I was having heart attacks for 6 years.
Wow.
And that probably when I gave birth to my youngest, that I had tore my left coronary artery and started building up scar tissue, which would cause the heart attacks. But I didn't know that's what I was having.
So silent MIs, as people might call them.
Right, right.
Whatever that is.
Well, kind of silent. You know, I would go unconscious, and my son would say, "Do you want me to call 911?" No, I'm going to be fine. So finally, I went to the emergency
you
room.
are stoic.
With all right-sided pain.
Right.
So women need to listen to that. You know, right-sided arm pain, jaw pain, ear pain, and in my chest. But I was, chewing Tums or whatever I could find.
Yeah, it's interesting, and I wonder, because I read about women and heart disease, and the highlights are not the same ones that men have, which are, the shortness of breath, that kind of thing. It's much more, believe it or not, things like depression, difficulty with sleeping.
Right.
I mean, did you have any of those kinds of symptoms that were sort of eking up on you?
I don't remember. Did I?
Yeah. Hard to remember.
I don't think.
Who knows? It
Yeah,
doesn't seem that way,
when you
right?
have little kids, you
Yeah.
just keep going.
You figure,
just
well,
do what you
don't
have to
sleep
do.
anyway.
No,
Right.
right.
That's right.
Who cares if you don't feel
Sure.
good? But then I finally went to the emergency room, and that was pretty much all I remember. Like, it was, they told my husband probably that I wasn't going to make it, and a lot of things happened. And then finally I got to the point where they could transport me to Innova Fairfax, and then one thing after another happened. Then I got on the list, and
How long did it take once you were on the
10 days.
10 days. And you were in the hospital the whole time?
Really,
I mean, you were
really
not stable
sick.
enough to go
No,
home,
no.
right. So you were fortunate you could be on the list and get taken care of that quickly.
Right, and then fortunate that there's a transplant center so close to us, because I wouldn't have made it anywhere else.
Right.
Yeah,
and I think that I'm hearing that we're lucky to have Innova Fairfax and this program of transplant medicine so close by, because I can't imagine there are many places you could go and 2 days later, 3 days later, or a week or 10 days later get an organ to be transplanted. The tough thing that I need to hear about, we all need to hear about, is what happens. You get a lung transplant. Obviously, you go through the process of making a decision. People are gravely ill. They need it. What happens after you get the transplant? Is it a very complicated recovery? What are the odds that you're dealing with in terms of how long you can live with a lung?
Yeah. It can be complicated, and I think you've heard some of the spectrum of patients in the hospital for maybe a week minimum to a couple of months. And generally, the sicker you are going into the transplant, the more likely it is you're going to have a rocky course post-transplant. And what I always tell patients, and what we always try and hammer home, is that having a transplant is a gamble. It does carry with it significant risk. It's like trading one disease for another. But the time to have a transplant is when the gamble of not having a transplant is greater than the gamble of having a transplant. So it's playing the odds. If If you look at the 1-year survival with lung transplants, around 80%. The 5-year survival is around 50%. At our facility, we're doing a little bit better. Our 1-year survival is around 87, 88%. Nonetheless, there's still a chance, 12, 13%, that you're going to be one of the ones that aren't going to make it through the first year. And patients need to know this and be prepared to accept that risk. So the example I give patients is, if I can tell you that you have an 80, maybe 88% chance of surviving 1 year, I think if you don't have a transplant with your underlying primary disease, COPD, IPF, cystic fibrosis, pulmonary hypertension, I think your chances of living 1 year are 50-50, then you go with the thing that gives you the greatest odds. But it does carry with it significant risk. So even if you have a transplant and you do well, you are on medication for the rest of your life, immunosuppressive medication, medications to prevent various infections. And when I say trading one disease for another, you might be getting rid of whatever the underlying primary disease is, but you're opening up yourself to a whole slew of new potential complications, from diabetes to hypertension to renal disease to various infections to acute rejection to chronic rejection. What we tell patients is that we know you're going to get some complication at some point. We just don't know what it is and when it's going to happen. And then we do the best we can. We try and maintain patients as best we can. We watch them very closely, and we try and pick up problems as early as possible. And that's how I get to know all these guys very well, because I see them in the clinic all the time, to make sure that we pick up on problems before they become out of control and unmanageable.
And when we talk about rejection, it's the basic body immune response to a foreign tissue. So everybody's in chronic rejection. It's just some are better controlled than others?
Well, acute rejection is, we kind of expect that probably about 60-70% of patients will have at least one episode of acute rejection. Sometimes they don't even know about it, and sometimes it's clinically manifest with shortness of breath, maybe something on the X-ray or the CAT scan. And generally, we're pretty good at treating it with high-dose steroids. The thing we worry about mostly is chronic rejection, because if you look beyond the first year or the second year, the thing that is most likely to get patients is chronic rejection, or the entity that we call bronchiolitis obliterans, which is destruction of the small bronchioles. If you look 5 years out, probably about 50% of patients have some component of chronic rejection. And in truth, if you look at any patient who is more than 5 years out and take their whole lung out, which we're not looking to do, but if we were to do that, we probably would find little pockets of chronic rejection here and there. And it's not necessarily a death sentence. We just try and maintain patients as best we can. Sometimes they lose lung function as a result of that, and we focus on trying to prevent further loss of lung function, prevent things like infection, and try and maintain as good lung function and quality of life as we can for as long as we can.
It's been a lot of work going through some of these medical episodes. You guys have suffered, yet you've rallied and you've celebrated. And it's a pretty amazing thing to do. You're in chronic rejection.
I am.
Can you get another lung? Does it happen?
I've been told that that's a possibility. Yeah. Yes, I'm not sick enough at this point to be relisted, but that's a possibility.
Would you do it again?
You know, that's a tough question, because I would want to do it again, because I like my place on earth here. But then on the other hand, lungs are so hard to get. You know, if it was a kidney or a liver, I would definitely say yes. But lungs are so hard to get. Then you kind of wonder if maybe somebody else should have the same chance that I did, especially since I'm hanging in there for so long. So, and that's an issue that I've learned other people who are possible retransplants are also struggling with.
That's it's a very personal perspective, and I really appreciate it. It is an amazing thing to ask for people to have their organs ready for donation. And I know we have someone from the foundation that is at Inova that deals with trying to procure organs and support the transplant program. Hal, tell us a little bit about, is it Real Diff? And I know that we have Real Diff we can put up on the screen with its phone number and website at Inova.
Sure. Well, my role is more in looking at what type of research possibilities. People know Inova Fairfax Hospital as a great place of caring. But we also, under Dr. Nathan's guidance, over 10 years now, has been leading a research effort into post-transplant research, which there's not enough of. And so we've gotten together a group of these post-transplant patients that want to raise money to support his research, to innovate, and to find more ways to support. I have to quote Dr. Nathan here, who uses a beautiful analogy of his research in that he would like to build a scaffolding under each part of the different areas of crisis that perhaps a transplant or advanced lung disease patient experiences along the way. And if at each point he's able to develop more alternative therapies, then we have a way of success. And this group here that you've just been listening to, that's so wonderful, have bought into this, and we have been able to start to underwrite some of his research and to find more initiatives. So I believe there's on the screen of the TV is a phone number you can call if you're interested in talking to us about how you might support what Dr. Nathan is doing at Inova.
And there are other resources that people can track down on transplants and organ donation. I think it's really important for everyone to consider at least committing that they would donate organs if they were in some kind of accident that would allow them to donate a healthy organ to a needy recipient like you folks are. And we have www.unos.org, which is that place. And of course, the transplant program with Dr. Nathan. And I do really thank you all. And I thank you all for being here. It's a wonderful story, and I think you've helped our viewers learn an awful lot about what it takes to really find joy in this world and to keep plodding forward. Anyway, I thank you all for joining us. Until the next time, I'm Dr. Russell Libby, looking out for your health.